Welcome, friends. This is Dr. Sharad Jaitly from New York. Thank you for visiting and associating with MuniMeterHealth.com, your favorite website, which is dedicated to teach you about the human heart and its illnesses. We have incorporated a brand new website where I talk, write, and sketch at the same time while concentrating on my other stuff as well. So we're gonna be using this more and more into our armamentarium, into our website. Let's draw the heart for a second here, so this way we can tell you what subject we're going to delve into. Our subject that we're going to delve today is stent versus the CABG, or stent versus the bypass. How do we approach with which patients? Now, this is my experience that I'd like to share with you. Here's the heart from the outside view. Here's the heart from the inside view. Obviously, the interior structure looks more or less like this, where you have a tri-leaflet tricuspid valve, and of course you have your aorta right here, so that's an aortic valve. These are your mitral leaflets, and then you have your the pulmonary artery here. So this being the right side, this being the left side, as you know, and this being the right side, and this being the left side. So right ventricle, left ventricle, RA and LA. And these are your tricuspid valves, mitral valves, aorta, and pulmonary artery. So now when you look at the artery comes out from here, and this is your LAD, it'll come out like this, and then the circumflex will go around like this, almost the border of your left heart border. It'll be giving you branches here, so also you'll have branches here. Some of these branches will be merging with each other. And then you have the right coronary coming out from this cusp, the right coronary cusp, and that'll traverse through and then give off a branch here. It's called the posterior descending, and then you have this branch is again merging into the apex. So in general, this is what it looks like externally, the plumbing of the heart, and this is the internal plumbing of the heart, if you will. Now, we know stents are required at times when there is an obstruction pattern seen. Now, say if you have an obstruction in the LAD here in this region, now that's almost the mid-LAD. One can go ahead and put a stent here. So if you put a stent, obviously you'll be able to open the artery nicely, and as a result you will be able to restore the blood flow to the distal artery. Now, if you have multiple obstructions, for instance, now you have an obstruction here as well in the RCA, which is, say, proximal RCA. You have an obstruction in the circumflex, and on top of that you have an ejection fraction which is low. If your ejection fraction is low, and say it is down to 35%, you're looking at 3-vessel disease with a lower ejection fraction. So there, a CABG would be helpful. Why? Because the chances of your putting stents into this area, and the third area, and then improving the ejection fraction simultaneously will take a very, very long time. So the clinical studies have shown that and invariably what happens is one or the two or the three of the stents will be stenosing, and this ejection fraction will fail to improve to the level where we want it to be. Remember, the ejection fraction has to be 55% or more. So the clinical studies are based on what the results showed over a period of time. The results clearly showed that if you have 1-vessel disease in an acute setting, a stent is helpful. If you have 2 or 3-vessel disease in the presence of ejection fraction being less than 35%, a CABG is helpful. Now, you may choose in between, because there's always a gray zone in medicine, I always say, where you have, say, 3-vessel disease, but your ejection fraction is normal. What do you do? Well, depending upon how bad the 3-vessel disease is, or how non-approachable, non-passable is the 3-vessel disease is, one can or one may decide to give stents, not necessarily at one do, but maybe at 2 or 3 different operations, so 2 or 3 different procedures at different stages, we call it. So a stents and versus CABG is very clear. You want to establish if the ejection fraction is less than 35%. Another good indication is if the patient is diabetic. Remember, do not forget, if the patient is diabetic, you shall have this as an issue, because ejection fraction, regardless whether it's 35 or not, if these patients are having 3-vessel disease and they have diabetes, they're better off getting a CABG also in that setting. So just so that you know, on MuniMeterHealth.com, we like to quickly summarize our subject. Stent versus CABG is a very, very important entity and a common discussion that's ongoing, but recent studies again have shown that CABG is more superior to stents. It's more definitive way of treating the patients, specifically so if you have ejection fraction less than 35 and the patient is diabetic and you have 3-vessel disease. 1-2-vessel disease, you can offer a stent as long as it's approachable, passable, and which is amenable for stents as well. Thank you so much for your interest, for watching MuniMeterHealth.com, and looking forward to seeing you more in my next video.